You just ask the questions, and then, as far as we get, it's okay. If we don't get all the questions, it's okay as well.
Okay. So, good evening, everyone from India. I'm Dr. Gagandeep Kaur, welcoming you all to Global Interdisciplinary Summit 2020. So, moving ahead with another tremendous lecture by Dr. Markus. So before moving on to the session, I would like to guide everyone to go through the details, and for the registrations and the speakers schedule, you can all go to the links which are present in the description box. So talking about Dr. Markus, Dr. Markus is basically Professor of Restorative Dentistry, Chairman of the Department of Preventive and Restorative Sciences, and Assistant Dean of Digital Innovation and Professional Development at the University of Pennsylvania School of Dental Medicine at Philadelphia, where he was also founded the Penn Dental Medicine CAD-CAM Ceramic Center. Dr. graduated from Albert Ludwigs University in Germany and was awarded additional doctorate degree, a postgraduate certificate in prosthodontics, and most recently, professor from the same university. Dr. is co-founder and past president of the International Academy of Adhesive Dentistry. He is a board-certified diplomate in the German Society of Prosthodontics and Biomaterials, and a member of multiple other professional organizations, including the European Academy of Aesthetic Dentistry, the American Academy of Aesthetic Dentistry, the American College of Prosthodontics, Academy of Osseointegration, and OKU Honor Dental Society. He serves on the International Journal of Prosthodontics, as well as co-author of the international bestseller, Evolution, Contemporary Protocols for Anterior Single Tooth Implants. Doctor is the recipient of multiple teaching and research awards and has published and lectured extensively on dental aesthetics, restorative materials, and implant dentistry. So I wholeheartedly welcome you, sir. And now the session will be quite interesting because we'll be having a lot of questionnaire discussion with Dr. Markus. So moving ahead with the questions. First, so as a researcher and clinician, how do you select dental materials?
Well, can you hear me well?
Yeah. Okay.
Good. Well, good morning, good afternoon, good evening to everyone. Thank you so much for joining us. It's a great pleasure for me to be here with you and share our knowledge. This is the wonderful thing about the very bad experiences right now. But one thing is we connect even more, I think, with people all around the globe. So thank you for the opportunity. Because what is very important for us and for me is that as we are, professionals, that we share the proper messages. And unfortunately, we hear also, even though we have all the things available now on the internet, but there's also a lot of misinformation out there. My role being a scientist and a clinician, both basically, is to help, spread the right message. And that is, to how do we select materials in the restorative world and how do we use them properly is the key for success. Typically, when you ask me about how do I select a dental material, of course, I would say there's three different factors. First of all, the concept is that we want to be evidence-based today, right? Evidence-based is the quick or the great predicament of what we do. We want to be evidence-based, but evidence-based, and there's a very nice definition from the ADA, is not just the science. The science is of course important. The scientific aspects of how the materials that we have available, are there clinical trials, randomized clinical trials is one part. But then another part is that, what is your expertise? Because not everyone has the same level of expertise with a certain material, and that will influence the outcome. And lastly, what we sometimes keep forgetting is, what does the patient really need? What are the needs of our patient? These three factors are, for me, evidence-based dentistry. The scientific knowledge, the information we have from the research, then what are the expertise level? Because we did a number of studies where we looked at, for example, bonding agents, how much your expertise level influences your success rates. And then lastly, what we keep often forgetting is, what does the patient really need? And I have put a few slides together, if I may pull them up for you. And if I share my screen with you and I show you a few slides on the topic. You should see it now. And hold on. So my idea, as I mentioned, it's not my idea, it's a general idea what we discussed at the school level, dental level, and the ADA came up with this classification, by the way, is again to have this combination of what is the best scientific evidence, what is my expertise, experience level, and what are the patient needs. And the patient needs, specifically from an aesthetic standpoint, is of course something you have to take in consideration when I make a selection for a material. One thing also, there is not one material for everything. The materials that we have available, from metal alloys, ceramics, composites, for indirect restorations, there's a wide range that we can use based on the specific needs of that patient. And there's nothing wrong with using a gold restoration crown or using a gold onlay or using a ceramic, depending on what the patient needs. And by the way, we put that together in a recent article, if you want to read that up. And we talk about aesthetic dentistry, on the evolution of aesthetic dentistry, where we kind of go back 100 years and look at what happened over time in aesthetic dentistry in the journal Dental Research, if you want to read up on that. Nowadays, we're in the age of CAD-CAM technologies, and many of the restorations that we are fabricating, specifically at our school, a high percentage is done with CAD-CAM technologies now, either in the laboratory or chair side. And the thing with CAD-CAM, we have this whole range of materials available as we had, pretty much before, and even more so. So we go from ceramics, metal alloys, polymers, composites, acrylics, and waxes that we can mill or fabricate in other ways using CAD-CAM technologies. As a prosthodontist, restorative dentist for indirect restoration, of course, one of our favorite materials is ceramics. And with ceramics, we can mimic the tooth structure very closely, as possible, and being able to also have long-term success rates with that. We talk about ceramics. And people always ask me, so how do you make a decision what ceramics to use for your indirect restoration? And I have to say, well, there's different factors we need to take into consideration. One is physical properties. What is the fracture strength that the material offers us? And we know that silica-based or feldspathic ceramics are at the lower end of the physical properties. Then we go up, lithium disilicates or lithium silicates, high translucent zirconia, then the conventional zirconia that as we have available today, we go pretty much up this ranking from fracture strength. And another very important property when you talk about aesthetics is, of course, translucency. And translucency goes actually the opposite direction. That's why we like feldspathic ceramics, because they have, very high translucency versus the more higher strength material because of their structures, may not have as much translucency. And if you ask me now, what am I using as a criteria for selection, I just combine those two graphs. And then those two graphs just show me the following. And I ask the same question as I asked before. What does the patient need? What are the patient needs? Do we need translucency? Do we need more aesthetics? Or do we need more strength? If I need more translucency and strength is not as important, I go to the left-hand side of the screen. If I need more strength and aesthetics may not be as important, multi-units, maybe implant components, we go to the right-hand side of the screen. Understanding for success, the ones on the left-hand side, unless you have a coping or a framework, will have to be resin bonded, versus the ones on the right-hand side we consider cementable due to their inherent strength. And over the years, just show you a couple of examples here where we have used CAD-CAM technologies and making the decision process of what material to use based on the surrounding dentition and the patient needs, as I just mentioned. When you look at the aesthetic properties, we say, you know what? Let's take a look. If I have to, for example, replace one, central incisor, let's take a look at the surrounding dentition, and then we make our decision. And we have all these materials available here. For example, we started using CAD-CAM technologies more and more, chair-side scanning, and now even also, in school or in office milling, which we have used quite successfully over in the recent past. And you can see, of course, it starts with scanning technologies. And by the way, if you want to read up on that, we have just published not too long ago an overview over the state of chairside digital dentistry, the materials and technologies that are available right now. You can look that up and read up on that if you want to. As I mentioned, at the University of Pennsylvania, where I am chairing the restorative department, we have included and implemented these technologies quite a bit to teach our students with the latest technologies and also make them ready for the practice of today. And you can see we just have opened a chairside laboratory where we teach our students how to mill these restorations if they want to do that in their offices, and then also finish them if they need a furnace or if they need to polish them, and how they finish those restorations. We have looked into CAD-CAM technologies on the laboratory side for a number of years, but more recently, when we were ready for the step in going into the chairside milling or in-office milling, have implemented that even more, I would say, comprehensively. And for example, in this situation, then going through the digital workflow and using a hybrid ceramic block for that specific case. And as I mentioned before, also the CAD-CAM materials that we had available in the laboratory, most of them are now available also for chairside digital dentistry or in-office milling and fabrication. The ones on the left-hand side, the composites, hybrid ceramics, or resin nano ceramics are polishable materials. You don't have to put them in a furnace, versus the ones on the right-hand side, feldspathics, lithium silicates, and zirconia, we need to put them in a furnace. Again, it's just a clinical example of how we then finalize this restoration, this mill in about 8 to 9 minutes. Very quickly, you polish the surface, and you can get, based on the specific situation in that patient, some decent results with that. The ones on the right-hand side require staining and glazing. And we can, for example, if we have a higher degree of translucencies, then use a feldspathic ceramic block, for example, and then trying to mimic that specific situation closely by selecting the proper material, which is more translucent in this case, and then finalizing it with this restoration, which was fabricated with in a chairside mode in our in-office laboratory. Understanding though, this is a feldspathic ceramic crown now, or silica-based ceramic, we need to bond this in place because, as I mentioned before, they may not have the inherent strength to be cemented. We have to use proper pre-treatment of the tooth structure, using a composite, and then using the material pre-treatment, which in this case is, of course, hydrofluoric acid etching and then silane application. Lithium silicates, one of the most popular materials also in our clinics for single unit restorations, monolithic ones. You could see we worked with this also for many years, and we can get very nice results with the lithium silicates, which is somewhere in between. They have a nice level of translucency. They have some inherent strength. Their inherent strength is, as all ceramics, is actually increased by resin bonding. So you may not necessarily have to use resin bonding protocols here based on the thickness that you have. But if you are below 1.5 millimeters thickness, it's highly recommended to use resin bonding for your lithium silicate materials restorations. Okay. Above that, you may select a cementation protocol with conventional cements, but typically we recommend to go more for the resin bonding, because we know we can increase the fracture strength tremendously by using resin bonding with that. You can see we have long-term success rates that are quite high, showing the success of these materials. As I mentioned, we had focused on ceramics quite a bit over the years in also CAD-CAM technologies. And I still believe that in some instances, when you have to mimic a very delicate situation, as you can see here, the natural teeth, and I have some very intrinsic properties when it comes to aesthetics. Plus, I have to try to cover and block out that cast gold post there. And in these situations, even though monolithic zirconia has become so popular, we still like to use a layer type of restoration, blocking out that gold cast post and core underneath with a more opaque zirconia, and then having a dental technician mimic the natural tooth structure as closely as possible, building it up with porcelain built up as we have done traditionally. And I still believe in many of those instances that is certainly the way to go. So this is was just a little introduction about the different materials that we're having. What other questions do you have for me?
Yeah, okay. That was quite interesting, actually. I wanted to ask whether your students are like milling the prosthesis on their own.
They're learning it, yes. They're learning that. So we have a laboratory that is specifically assigned for that. And I mean, you could do these restorations within one patient visit, but the students are learning, they're starting. So they will still, bring the patient back another time when they finish the restoration. But we have these milling units available for them. We have dental technicians specifically assigned for them to help with that process and to understand how to treat the materials. And as you know, they have to be treated very differently, depending on what kind of glazing you're using for the different ceramics, but that's what they're learning. And it's surprising how successful it has become, actually,
Definitely so. And what will you comment upon the strength of zirconia versus porcelain?
When we talk about zirconia, and I can, if you want me to share another couple of slides, if you're interested in that.
Definitely, I would love to.
Okay, I'll show you that. So there's a few things about zirconia. I mean, we talk a lot about it, but I also want to, everyone who listens, there's some misconceptions out there, and I want to clarify that for everyone. And one of the misconceptions is I hear people say, well, zirconia is a metal. Okay, please understand, zirconia is not a metal. And if we think it's a metal, we may do mistakes, because then we use it in circumstances where we shouldn't use it. And then people say, well, but the zirconium is a metal, and it's true. Zirconium is a metal, but zirconia, as we use it in dentistry, is zirconium dioxide, which is a ceramic. It's the crystal of zirconium, and by definition, inorganic, non-metallic, and mostly crystalline solid. And it's important to understand the difference, because, as I said before, and here's maybe a nice example, explanation of it. When I'm using a metal and I put a stress on it, then it has the ability to undergo plastic deformation. It can deform itself. So when I have a very heavy bruxer, I'm using metal occlusion. No problem with that, because a ceramic cannot do this. It's a brittle material. If you make it too thin, if it has the stresses too high, it will break, because it can deform itself not as much in the plastic mode as the metal alloys do. So I have to be very careful with that, understand that based on the strength of the ceramic, it needs a certain thickness. And we need to keep that in mind as well, specifically when we talk about the newer ceramics and newer zirconias that we have available today. And, when we look at some of those zirconias that we have, and here's just an example, again, like a little clinical example. There's different generations of zirconia that we have available right now. And the first generation was, of course, more opaque, and was the strongest, though, with about 1,200 to 1,500 megapascal. But it was more opaque because of the alumina content. And this is why the second generation, then, the alumina content was changed. Material was slightly weaker, though. And also, what happened with this second generation lower alumina content is that we had a higher degree of a phenomenon. It's called low temperature surface degradation. And what happened then is that people said, you know what, let's keep the alumina the same, but change the particles by changing the yttria, which stabilizes those particles content. And that causes a higher degree, a higher percentage of cubic particles. So we all talk about cubic zirconia, and cubic zirconia is a certain particle size and formation that is more translucent. When I increase the amount of cubic zirconia, the zirconia becomes more translucent. But what also happens is that it becomes weaker. So the fracture strength of the cubic zirconia is less. And so we need to understand that when we talk about those high translucency zirconias that we have available now, that they don't undergo transformation toughening. They are much more translucent, but when you look at the fracture strength, you can see that it's much less than the conventional zirconia, still more than silica-based ceramics, but much less than the conventional zirconia. That's why you have to be careful and you have to have the right thickness in order to pretty much make that work. And by the way, now we even, starting to talk about printed zirconia, and we're looking into those options as well. And this is pretty much, what I want to share with you about the zirconia, at least from a standpoint of fracture strength and developments that we have available there. A question that comes up quite a bit is of course that of cementation. I don't know if you want me to speak a little bit about that, because that's an important factor in how we use these materials. Yes?
Yes,
Okay.
sir. Next, moving on to like cementation of zirconia, or it should be bonded. What's your view on that?
Thank you so much. No, that's why it's this is as I mentioned before, because the ceramics are so dependent on thickness and strength and maybe reinforcement, the use and selection of your cement is very important. So what we recommend to do is, for a conventional crown with appropriate thickness, okay, a conventional crown, appropriate thickness, good retention, you do not have to bond zirconia. You can use a conventional cementation. You can use resin-modified glass ionomer, you can use glass ionomer, or you can use also self-adhesive resin cements. Self-adhesive resin cements have a nice advantage because they have some bond strength, not a whole lot, but some at least, and you can easily use them without having to use a pre-treatment of the tooth or pre-treatment of the restoration. The only thing we always recommend to do, even with the self-adhesive resin cements, based on our studies, is to use air abrasion as a first step. And with the air particle abrasion, we can then, increase the bond strength to a certain degree. Yes, and using, aluminum oxide particles and air abrade that. So for the conventional crown, don't worry about bonding. It's different, of course, when you have a situation like this and you want to use a bonded restoration. This patient, was not old enough to have an implant placed. Some people may not have the money. So there is a very nice alternative, I find, and we do more and more in this patient, was after orthodontic treatment or, and didn't have, lateral incisors. A very nice, elegant way is actually a resin bonded bridge. But resin bonded bridge, not made out of a metal framework, but out of a ceramic framework, a zirconia framework. And we have done tons of these and over many, many years, and it's very easy to do. You have a very slight preparation on the palatal aspect. We can then, if you understand how to do it, you can be very successful with it. What's different from a metal, and that's why I showed you that graph with the, with the modulus of elasticity before. You want to use only one retainer. You only need one retainer, because if you have the two teeth connected with the two conventional retainer design, we have seen a number of fractures. But if I leave only one, success rate is actually much higher. And then I hear people say, oh, you cannot bond to zirconia. Well, look at these studies from Matthias Kern's group in Germany and many other groups who looked at this. And they can tell you that success rates with resin bonded bridges made out of zirconia, extremely high. After 10 years, almost 95% success rate. So you must be able to bond to zirconia, but you have to know how to do it. And that is the key. So, but 10 years, no deep bonding, if you do it right. Starts, of course, minimally invasive prep. Do not remove too much of enamel. Keep it very little. And if you have enough space, you have almost no preparation. Keep one retainer. Don't connect it to, because that may break more easily. And then air abrasion is the first step of your bonding protocol. We have looked at this for almost 20 years, and we've done thousands, literally, of specimens looking at this specific topic. And we always come to the same conclusion. Right now, the best way to treat the zirconia for bonding is air abrasion. Particle size doesn't matter that much. You can go small because some people were afraid of maybe going too large particles and then damaging it. Use small, low pressure, it's okay. At least do it, okay? It's a very important step in the process. And then we want to use a primer that has the ability to chemically bond to the zirconia, like a silane to the silica, but that doesn't help you here. Acid etching, silane does not help on zirconia. Here use air abrasion and a special primer. So please read instructions of the primers you're using, if it is for zirconia, yes or no. This monomer has the ability to bond to metal oxide, like zirconium dioxide. And this is why this is one primer containing monomer that has become very, very popular. Many of the manufacturers, I'm just showing you one example here, have now their own zirconia primers, which work very similarly to get better bond strength to zirconia. In these cases, where you rely on bonding. I found always difficult that people keep it in their mind. This is why I made it actually very, I made an acronym for this technique, air abrasion, primer and composite, and we call it the APC technique. And so this is nothing new. It's just summarizing our research over the last 20 years. And, if you want to read up, of course, we published that in the early 2000s. More recently than when we started to call it the APC technique in the compendium, you can look it up on the internet as well. If you just put in, APC and then, Blatz or Zirconia, you will find it. And we also did a summary in the Journal of Dental Research, a more scientifically oriented journal on the same topic, which summarizes the information that we have available on bonding to zirconia. Because I hear it so many times, people say, oh, you cannot bond zirconia. Yet there's all this information out there in order to make this work. And how this works when you look at this bonding interface is actually quite interesting, because some people say, oh, how does it work? I don't understand. Let me explain to you. So here, if you have a composite to zirconia and you don't treat the zirconia, you have no bond strength at all. When we're using only air abrasion, you have some good bond strength, but not everywhere. And then the same is true when we only use a primer and no air abrasion, it's also very limited. Only when you combine the two, we find those bond strength to be better, but also we can look at the interface to be much better for adhesive bonding. And what you could see is actually that it's not just a roughening effect, because it's not like acid etching of a silica-based ceramic. It's more that you have these particles, and that's the interesting part, now slightly roughening the surface, but also having these particles embedded into the surface. And by doing so, they're now available for bonding with this primer, the special primer for zirconia, and then you can get these high bond strength and make these restorations like this one, last, as you can see, 10, 15 years in almost 90% success rates of the cases, if you know how you do it properly. And this is pretty much the message I have for you on how to bond to the zirconia.
Okay, so first you follow air abrasion, and then you follow the primer, and then you move on to composite. Don't you use bonding agent in between?
Absolutely. Of course, yes. I was just talking about that's. I'm glad you mentioned that. Of course, I was just talking about the zirconia surface. Okay, the zirconia surface is one aspect I was talking about. The other aspect is, of course, the tooth surface. The tooth surface, when you have your, you can do your conventional technique. Okay, have a lot of enamel. I still like a total edge technique with phosphoric acid. A lot of enamel, phosphoric acid, total edge technique. And so this is the other surface. Exactly right. I'm glad you mentioned that. There's two bonding surfaces, one to the restoration, one to the tooth. And they have to be treated differently, of course. And but also another thing I would recommend to do is if you select to stay within one manufacturer, and I don't care which one you're using, it's for bonding agents, but stay within one line. Many times I have people ask me, so when you put the silane, do you have to put your bonding agent? I said, it depends on your system. Some silanes required you put a bonding agent on top, others do not require that. So please follow the instructions. I know it's not always easy for us, but read the instructions and make sure it's proper for that. We have now some more universal, by the way, ceramic primers that have both a silane and also like MDP or a similar phosphate monomer that would work for both. But please read up on it, because otherwise you may use the wrong primer. And then if it doesn't work, it's not the material's fault if you're using the wrong material.
Definitely the procedure or the knowledge, actually the lack of knowledge, I would mention. Okay, so next question we have: what are your thoughts on zirconia for implant supported restorations?
So we do a good number, of course, as implant-supported restorations as well. And now we're starting actually, we have been starting that over many years, actually, to use, of course, zirconia more and more. Not so much because we're so much in love with the material, but because it has certain properties. But remember, when you select a ceramic, you have to make sure you can use it with the proper thickness. I've seen people using zirconia abutment, and then they prep the abutment, and the abutment breaks, and they wonder why. Well, if you make it too thin, it's going to break. So in the thin situation, I would still like to use a metal alloy and use titanium as the abutment material. Okay. The nice thing about zirconia, though, also now we can use it as a full contour zirconia material. So we can have with specifically when we have now angulated screw channel available, we can make those crowns full contour out of zirconia directly onto the implant without even using an abutment, without even using a cement. When we're using zirconia as an abutment material, we know it has many certain properties. And one is that bacteria doesn't like it so much. That's one of the advantages.
Better.
So, and biofilm that's one of the advantages. But soft tissue likes zirconia, and similar to titanium, it's very similar. Titanium, we have a thick oxide layer that makes it so biocompatible.
Yes.
And the soft tissue likes that.
Yes.
And of course, because and the same is true for zirconia, or very similar. It's different. It doesn't have a thick oxide layer like titanium, but since it's zirconium dioxide, it has it already in the material. So there's a little difference there, but it has similar effects on the soft tissue, that you can get some fibroblasts and some nice epithelium attachment to the abutment surface. And so this is one advantage over, for example, gold alloys and other alloys that we had used in the past. And plus we have the aesthetics. So if you sometimes wonder if you have a gray shadow around the implant restoration, it may be due to the abutment material. And then, we rather switch to an all ceramic. It's more expensive. That's why you have to think about when to use it. But in the aesthetic zone, it can make a big difference if you're using a more tooth-colored or white material. And so we've seen, and I said, this being quite advantageous. One thing you want to be careful, though, if you're using a full contour zirconia crown, for example, on abutment, that you don't have a glaze on it. The glaze inhibits the tissue from going onto the zirconia surface. So when you have a full contour zirconia crown on an implant and you have a glaze on it, you want to polish that off in order to get a better soft tissue integration there.
Okay. And like whole surface polishing, or only the cervical portion where the soft tissue is going to have a color?
Excuse me?
So you were mentioning about that if glazing is present on the prosthesis, so we need to polish that, right? For the attachment of the soft tissue. So I'm just asking whether you are suggesting for polishing of the whole prosthesis, or only the cervical area where the soft tissue is going to adhere.
It's very good. No, it's only necessary in the area where the soft tissue will attach to the abutment. The other part of the restoration, you can use a glaze to make it, or stains, to make it, look more natural and customize it. However, we also like a polished surface in the occlusion or function bearing areas. So when you have a posterior tooth, for example, and you have occlusive contacts, I like that surface to be polished. It's better to be polished. It's less abrasive, a high polished zirconia is much less abrasive than, of course, a coarse one and even a glazed one.
Definitely.
Even a glazed one. If you have a high polished zirconia, and some people are worried, by the way, about wear of the opposing dentition and about opposing materials. However, when you think about it, it's like sandpaper. When you have a coarse sandpaper, it's more abrasive, and a fine sandpaper, not as much.
Yep.
Zirconia is very small particle grain size. Okay, some of the veneering porcelains we're using have much bigger crystals in them, and so they may be even more abrasive. However, of course, it's not the hardness that creates a wear, but if you have a rough surface and a hard surface, that's not good. This is why whenever you have zirconia, adjust it. Use a a yellow ring diamond, to kind of polish it off slightly, and then using a polishing kit. There's several polishing kits available now that tell you, coarse, medium, fine. You polish the surface, occlusal surface, soft tissue area bearing surfaces should be polished. We find it to be the best.
Okay. Next question we have from audience. One is from Dr. Danny. What are the dimensions of a zirconia preparation?
The dimensions of a zirconia preparation? If I make, you mean preparation, crown preparation, or sorry?
She has not mentioned actually. For crown, basically, like it would be.
Typically, I mean, for the zirconia, for a full crown, we use a very similar, preparation design and preparation as compared to your conventional crown preparation. There's no difference. You just want to be careful that when you have a high translucent or ultra translucent zirconia, that you have the proper thickness, which should be, in the anterior at least 0.8 millimeters, and in the posterior at least 1.1 millimeters. You can go slightly thinner with the conventional zirconia, but I would be very careful with that. Typically, we recommend to go at least 1 to 1.5 millimeters, especially in the posterior, and then you're somewhat on the safe side. You don't want to make it too thin because, again, it's a ceramic, and the weaker it is, the thicker you have to make it. So the high translucent zirconia, make them slightly thicker than your conventional zirconia.
Okay. So, okay, we'll move on to the next one. What is your view about zirconia implants?
Oh, thank you. Yeah, zirconia. I mean, I don't know if it's a topic all around the globe, but I hear it more and more in some areas in the US that people talk about zirconia implants and want to know more about it. And then it's funny, when you've been around a while, like I have in dentistry, you've seen things come and go and then come back again. and it's why we had talked about zirconia implants for years and years in Freiburg, Germany, where I'm from, and went to dental school and was also a professor there. We had used zirconia implants for quite some time, and but we learned a lot. And in the beginning, when we thought they have to be exactly the same as a titanium implant when it comes to shape, form, dimensions, and surface, we were not as successful because the material is different. This is why I also showed you this little graph earlier. We did actually some studies analyzing how the forces are being distributed into the bone, okay, with both titanium implant and then the zirconia implant. And what we could see that with the zirconia implant, there was more forces distributed into the coronal areas of the bone versus with the titanium implant, you could see an even distribution along the implant body. And we saw the same thing clinically, actually. And that has to do with the modulus of elasticity, how these materials behave under stress. And this is why, you cannot do the same for same shape with the zirconia implant as you can do with use for your titanium implant. I think there's some manufacturers now that are coming out with zirconia implants, having learned from that. You can see they're using a different shape. They're using different surface configuration, which is important as well. And by doing so, and by the way, it's also many of these manufacturers using a different zirconia from your restorative zirconia. It's typically what we call a alumina toughened zirconia, which is a stronger zirconia. And that helps, of course, with preventing any fractures and that. I think there's a place for zirconia implants now that we have learned from the past, but we'll see if it will be really a replacement of titanium in the long run. We have to see. Again, this has different properties, and we have to be aware of that.
Okay. And what do you think that which one has the more failure rate, zirconia, titanium?
And again, and there's no direct comparisons, and we've seen higher failure rates in the past because we didn't know these differences. I think the current developments in the zirconia implants are very promising. Look very promising, but at this point in time, I have not seen direct comparisons between the two. But there's more and more data coming up that's very promising for ceramic or zirconia implants. And it's growing evidence, say this way. But for us to recommend it on a regular basis, we still need to see more evidence for that.
Okay, so we have next question. After air abrasion, zirconia might transform the phase, then become weaker. Is that so?
Yes, in theory, yes. And the question is how much that happens. And we did a lot of studies on that, how does air abrasion affect the surface? And it really depends on different factors. It depends on the particle grain size that you're using. It depends on the pressure. It depends on, but we found that even if you use a low pressure, if you use lower pressure, small particles, these effects are not clinically relevant. Okay, that they would cause clinical failures. However, if you don't use air abrasion, you will not have any bond strength. And this is why, of course, we have to balance it. There may be a slight weakening, and some studies showed that, specifically when you use high pressure and large particles. That's why we say you don't have to do that. Use small particles, low pressure, and then we get these results that speak for themselves, the clinical results that we have with the long-term bond strength there. But if you don't use any air particle abrasion, you will not get good bond strength, as I showed you. We also look at now, by the way, for the specifically for the high translucent or ultra translucent zirconias, looking at using glass beads instead of aluminum oxide. And that seems to be promising as well, because it may not damage it as much. If you're worried about that, I'm not, by the way, not at all. And we studied this for 20 years. But it's always, people always look for the problems, but honestly, I don't think there's a problem, because we've looked at it clinically as well as in the laboratory. Glass beads seem to be a good option as well. The moment you use glass, though, understand, you need a different type of primer that has a silane coupling agent in it. Or, you're using one that has both. And some of these primers that we have available now have both a silane and those phosphate monomers. And then, you're pretty much on the safe side when you're using glass beads, for example, as air abrasion. But quite honestly, we are not worried about using air abrasion for your bonded restorations, and they have not seen any fractures based on that.
So next we have the question that is zirconia could be discolored with time?
With time, again, I really appreciate everyone, sending excellent questions. The common thing would be no. Okay, it depends a little bit on the composition, of course. There are some, I would say, some less favorable compositions. If you stick to the reputable manufacturers and to the products that have been proven over years, you will not see a change in color. Okay, I have to caution though, and that's why I think it's a very good point, is that there are a lot of products flooding the market right now, zirconias, and there's a big, almost a zirconia war out there, and everyone gets cheaper and cheaper and cheaper, and you want to be careful with that, because yes, there could be some compositions that are not as stable as others, and that has to do both with the material themselves, the composition thereof, and the fabrication, the sintering process. If they're not sintered properly, you will get a very different material, which may not have the same properties. And there could be a possibility that if you don't use the proper material, that it loses both, of course, strength, it loses fracture toughness and fracture strength, and it loses also its optical properties if it's not fabricated properly. So there's a chance, but if you stick to the reputable companies, manufacturers, and you follow the instructions of fabricating and sintering, making sure that your furnaces are sintered, calibrated properly and sintering in the right temperature, you should be in a good shape. I'm not worried about that. I've not seen that.
Okay. So is there any relationship between the amount of the zirconia and the quality? Like you're saying that it becomes cheaper and cheaper day by day. So more the expensive, more is the quality. Is that so?
Well, of course, it's always difficult to correlate that. It depends on the specific manufacturer. You know, I would just recommend, you know, stick to the quality manufacturers, and I think you should be in a good shape. You know, so.
Okay, definitely. So next question is from Dr. Alberto. Could you explain why do you have more success in the single connector against two connectors, adhesive restorations on late roofs?
Absolutely, and that's, by the way, in the beginning, we did the conventional two retainer design, right? One side, one side.
Yes, sir. Yes.
And but then we could see a relatively, not very high, but, you know, 30, it is high, 30-40% of fractures, you know, and we said, you know what, why does it happen? And we didn't understand. But when we left, even though one had a fracture, but there was no reason to just remove it, right? But left the one in place and did not remove. There was no reason to remove the restoration just because there was one fracture and one abutment. Just make sure there's no sharp corners. Left it in place. We could see they lasted much better. So the secondary success rate was much higher. And we said, you know what? Let's not be stupid. Let's use only one connector. And the theory behind that is you have two mobile elements, okay? And when you use a metal frame, this metal frame has the ability to go under plastic deformation, so it works okay. A ceramic cannot do this. And something will give. And what we've seen that it may fracture on one of the connectors, the weaker one usually, of course, depending what the forces are. When we used only one retainer wing, we didn't see, of course, there was no fracture on one of them because it was only one, but we saw a much better success rate. And again, not over 90%, almost 95% when you do it properly. But it has to do with the modulus elasticity of the material. Ceramics are brittle, so when you use a ceramic, you want to use only one retainer. And it makes a lot of sense because, you know, you are minimally invasive. You don't have to prep two teeth. You just prep one tooth. Stay in the enamel. Make the preparation as little as possible. By the way, I don't know if I'm just learning all the online world out there, and just starting to go on Instagram and things like that. If people want to join us on Instagram as Professor Markus Blatz, I'm actually posting some of the preparation designs and suggestions there. It's a Professor Markus Blatz at Instagram, and we're gonna put some videos out there to show better how this should be done if you're interested in the topic, and it's actually quite interesting to see now that we are socially distanced in many areas of the world. I'm actually socially more connected. I'm glad we could meet. I'm glad to meet all the people that are following us right here. It's just amazing. It's a different world. And in some sense, we're getting actually better connected than we ever did before.
Connecting globally with people. That has not been, like possible years ago.
Okay. Yes, that is fantastic.
Okay, so we have we have a question. Is Emax stronger?
So Emax is, as you can see at the graph that I showed, the Emax is of course weaker than the Zirconia. Okay, however, and we do a lot of Emax restorations as well. It's a great material because it's somewhere in between. It has a nice translucency and has some nice strength features, specifically when you bond it. So you increase the bond strength, the fracture strength by using bonding tremendously. Okay, so when you resin bond Emax, you increase the fracture strength by almost doubling it. As a material itself, when I test it, as we test our ceramics, with a certain, strength test, it's a weaker material, yes, than zirconia, of course, because it has a different structure, it's still silica-based, but for single units, it's a great material. But the limitation is when it comes to multiple units, and that's, when the lack of strength plays a role. Of course, you could do also bridges with the emacs or lithium silicates. However, the connector have to be much bigger. So the weaker the material, the bigger the connectors have to be. And that, of course, sometimes may just not be possible when you have nice embrasure spaces, want to build that, so that's why it's better, to go to stronger material, to go to zirconia, for example, when you have multi-units, when you want to make a bridge and, get the stronger material. Lithium silicates we use quite a bit. I love it for specifically also onlay restoration. You can nicely bond it. Again, you bond it by using hydrofluoric acid and the silane coupling agent on top of that. Then you composite, then you do your tooth, of course, the tooth structure on the other side, and it gives us very nice restorations. And there, for example, I do not prefer to use zirconia. I don't use zirconia much for veneers. It's this where we're going to go into silica-based, like an Emax or feldspathic, depending on the indication and depending on the level of translucency. That's why I showed, I know I went very quickly through my slides, but I just want to make sure I can give you as much information as possible in the shortest amount of time. And you can see that the feldspathic porcelains are the most aesthetic, but also the weakest. And this is how you have to make your decision. What do you need it for? Uh-oh, I think I lost. I cannot hear you anymore. I think I lost. There you go.
Okay, so earlier you mentioned that zirconia is all hated by bacteria, right? So, like, what is the reason behind that?
No, it's just a structure that, it has possibly multiple reasons for it. That bacteria, of course, there is still some bacterial adhesion, and you can see some biofilm adhesion as well. But of course, these factors are multifold. It has to do with the surface structure, and specifically also with the roughness or lack thereof. And we're talking about polished zirconia again. The rougher the material, of course, you would expect more bacterial adhesion. It has to do with the material itself, which has a certain electric load, and then will attract certain pathogens slightly differently. And so these are all the reasons. There's multiple reasons for that. Why you see less bacterial adhesion to that specific material. But we have looked at that. In general, what's interesting is we see, of course, less bacterial adhesion to polished surfaces than to glazed surfaces. So they seem to be better also for soft tissue integration. Glazing, of course, though, helps us to customize your crowns, customize your restoration. So in most areas, it doesn't matter as much. It matters, of course, bacterial adhesion when you have an abutment, an implant abutment. That matters a lot. And but if you have a crown, full crown, and I don't think bacterial adhesion on the surface of the crown may make a big difference. But it does, of course, when you have soft tissue bearing areas or implant restorations, for example, where could be detrimental, of course.
Definitely. Okay, so another next interesting question we have. Okay, what is your view on the future of ceramics?
What I think right now, we look at all the different CAD-CAM fabrication processes, and I think the large percentage, I don't know, in other parts of the world, of course, it may be different, but the overwhelming percentage of restorations being done right now in our clinics are done with CAD-CAM. Even the cast ones, the manufacturers, they're milling out a pattern or a wax coping because it's just doesn't depend so much on the dental technician and just using CAD-CAM technologies for that. Right now, most of the ceramic restoration that are CAD-CAM fabricated are, of course, milled, and we have very good results with the milling. But I think in the future, once 3D printing will become more better, and more affordable, at least in that precision that we need, I think this could be the future. Instead of using subtractive techniques, such as milling, using additive techniques. And the advantage could be that we could possibly, or will, I'm pretty sure we will, we could layer materials through the printing process. Because right now, of course, we have very nice millable materials that have different translucencies, maybe even, or even different colors, polychromatic. But the plan would be in the future to have printable materials, printable ceramics that can then be layered, because in the end of the day, the layered restoration, where the technician builds it up, from the inside, is still the most aesthetic. Okay, because you build it up from the inside, like the natural tooth, is still the most aesthetic. And I lost you again. I can't hear you, but
sorry. Sorry.
There you go.
Okay.
No problem.
Okay, we have the next question from Dr. Maria. Up to how many units of zirconia crown is suggested?
That depends. How many units? That really depends on the specific material that you're using and the manufacturer. Again, we have different types of zirconia available now, so it really depends on that. With the strongest zirconia, we can do full mouth rehabs, and we do a good number of full mouth rehabs on implants, for example, 10 units, 12 units. You can do full mouth reconstructions with zirconia. There, of course, I would not recommend the weaker zirconia. I would use a stronger zirconia and use the proper connector size. When you design it on the computer will tell you what your connector sizes are, and you can say, you know what, this is not enough, I need a little more. But with the right choice and with the right design, you can go full mouth. There's no limitation for that. I wouldn't do it on teeth, though, of course, but on implants, yeah.
Okay. So what is exactly dimensions of a connector between two zirconia?
Oh, that depends on the material. I mean, you have to look into the manufacturer's recommendation there, because, as I mentioned, there's not one number. That depends on the specific zirconia type and product that you're using, because they may be very different. Like I said, the weaker zirconias, like the more translucent ones, may need bigger connectors, and the ones that are stronger, less. But again, the recommendations by the manufacturers are there, and just follow them. There's not one number I can give you.
Okay. So actually, this was being asked by me itself in a questionnaire, and I really wasn't confused. Like, what is the exact or ideal dimension? So we don't have much, right? So we follow
but there is, but it depends on the material. We know the dimensions, but it depends on the type of zirconia that you're using.
Okay. So next we have, which one is better for onlay posteriorly metal alloy or zirconia?
It depends. By the way, posteriorly, I mean, for onlays, if you like to use metal onlays and inlays, that's fine. Of course, one of the advantages of using a ceramics are they're more aesthetic, and you can bond them. I have no problem with using a metal onlay, gold onlay, and I like it. It's very long-term restorations. We know that partial crowns or partial coverage gold restorations last. We have data 35, 40 years, so nobody can argue with that. It's very difficult to convince patients, though, to use gold these days. Some like it, and that's no problem. I have one myself, by the way. Not a problem at all. But I personally am not the biggest fan of using zirconia for that, because we have very good results also with the lithium disilicate. So with the Emax, for example, in a bonded onlay, I like to use a silica-based ceramic, such as a Emax lithium disilicate or other silica-based ceramics. You can nicely acid etch them. So the nice thing about using a ceramic, an etchable ceramic, like silica-based, is that you can bond it. Okay, the gold, of course, we cannot bond easily. And by using bonding technology, we can make our preparations less invasive, and that's the key as well. We teach a lot of CAD-CAM, but we also teach be less invasive. We want to have our patients keep their teeth as long as possible. That is our role. And with bonded ceramics, we don't need to have any, retentive preparation design. Retentive preparation design is for materials we cannot bond, right?
Yep,
Amalgam,
definitely.
gold,
Yes, yes,
whatever.
yes.
So you need a
Yes.
retentive preparation design for that.
Yes.
For a onlay, bonded onlay out of ceramic, you don't need a retentive preparation design. It's not necessary. If you know your bonding technique, you make sure when you bond that you don't have moisture and contamination there, and you know the protocol, you bonding agent for the tooth, bonding for the restoration. You don't need to have retention. You need to have some maybe resistance form, but you don't need much of a retention form. So you don't have to have any parallel walls or 6-degree taper walls. Not
Definitely.
necessary.
Definitely.
And by doing so, you can be less invasive, and only focus on the areas that are really, have to be replaced, and then make a customized preparation design.
Okay.
That's the advantage. That's why that's why I like those bonded ceramic onlays very much.
Definitely.
And you can open. People say, well, maybe they don't last as long, and that's why they put the crown. Well, even if it lasts 15 years, and they can still do the crown later. But if I do the crown in the beginning, I don't help my patient keep their teeth.
Definitely. Okay, so we have one more question. Let's say if there is a fractured zirconia unit, can you repair the one in that 10 unit? Like if you're having 10 unit zirconia bridge, if one gets break off, so how do you repair that? Do you replace all of it?
No, yes, you pretty much have to. It's like you cannot solder it
Oh,
or anything like that. Unless, I mean,
okay.
it depends. Of course, if it's like, it depends on your design. That's why, it depends on your design. If you have a chance to maybe leave it even disconnected, leave it disconnected. It doesn't matter. But of course, there's no way to repair it. If zirconia fractures, you have to redo it. But if it's like a screw retained, I mean, it's as simple as just unscrew it and make a new one. When you see, by the way, when you see a fracture of zirconia, it could be, of course, that you have not enough thickness. But always, when you see fracture, when you see failures, always think about what was the reason. Because if you just redo it the same way, the same thing may happen again. So think about it. Was it that I had too weak of a connector? Was it that maybe the laboratory didn't fabricate it properly? Was it that my impression wasn't right? Because one thing you need to know about the zirconia, as I mentioned, it's a stiff material. It's a brittle material. So when you don't have passive fit, you may see fractures, okay? And this is why also when you have like a 10-unit implant restoration, when you try it in, don't screw everything in and then check for fit. You screw it in the most distal part, one screw only, and then you check the other implants, okay? And if it's a discrepancy on the other side, don't screw it in, because if you do, you put stresses on the ceramic and it will break. It's not the fault of the material. It could be that your impression was not correct, because in the laboratory, we can get we showed it in many studies, you can get excellent fit in the laboratory. Of course, if your impression technique is not correct, and then you have a different, it's different from the laboratory than in the mouth, then you will see fractures. Okay. That's why always, check your, when we always do a check of our impression before, in our master model, before we even, fabricate the final one. So we use the master model, and then we make a little jig, and we then have our implant impression copings put together with the GC pattern or something, and then have a little jig around it. And we try that in first before we even try in the framework. Make sure that your impression is correct. If you can see there's a discrepancy, you can just, take out that one impression coping, reconnect it in the mouth, bring it back to the master cast, and then either change your master cast or make a new one. And but then, I'm sorry, but you have to do this if you're using a ceramic, because it's titanium that gives a little bit, and you may get away with some discrepancies, but you shouldn't either.
Okay. Okay. So next question is, How do you remove zirconia crown? What do you recommend?
It's just it takes a coarse diamond, it takes lots of water, and it takes a lot of patience. It just takes time.
Okay, okay. So we don't have more questions with this.
Yep, I think we have exhausted the topic in a short period of time. Bang, bang.
But
As much
this
as information as possible.
actually people had a lot of questions and a lot of regards for you. This was quite an interesting discussion, and people coming up with their questions and all those problems which are usually they face daily. So I think okay, yeah, we have one question more. Is it possible to do cantilever bridge with zirconia in posterior area?
Oh, cantilever bonded bridge or cantilever bridge in general? You can do cantilever again, depending on. I mean, I would not extend it as much as I would do with a metal cantilever, so I would not go more than like one tooth, adding maybe one tooth to it. But I wouldn't recommend to do much more. With the metal framework, you may be able to have a longer cantilever, but yes, you can. Of course, bonded, by the way, resin bonded bridge in the posterior, I do not recommend. We have not seen good results there. So I would be very careful with that. There may be an exception when you have maybe missing premolar and you want to be very minimally invasive, but not for having chewing forces on a resin bonded posterior bridge. We were talking about anteriors just to help our patients with a very elegant, quick, 2-visit solution that can help patients buy some time until they can have an implant or something else. And interestingly, many of them, they say, you know what, I love it. I don't need anything else. That's okay.
Okay.
We love implants, don't get me wrong. But, we have to provide our patients also with alternatives.
Definitely. Yes, sir. Okay, we have one more. What about if the tooth or teeth to be restored were endodontically treated? Do you prefer zirconia crown over an Emex crown restoration, and why?
Again, it doesn't matter for me if the tooth is endodontically treated or not. Many times now, even endo-treated teeth, we do partial coverage, like in the posterior, for example. It's sometimes even the better way sometimes to do it. When you have a molar, for example, and have big access hole, and then if you would put a crown, you build it up and you put a crown, and the tooth structure is completely done and gone. In many of these cases now, we do an onlay, by not removing for the crown. If you have to, prep completely for a crown, of course, you remove pretty much
Yes,
sometimes
yes,
almost everything,
actually.
and it doesn't make any sense. So when you do an onlay and you just make a limited preparation of where the defects are, maybe you have to replace a cusp, and then you make a very slight preparation and make a little overlay with your preparation design, and you don't have to remove all this circumferential enamel and what's left of the tooth. In those cases, that's when I use, like I said, I like to use lithium silicate and not a full coverage crown. If you use a crown, it really doesn't matter. I don't think there's a difference, between using zirconia or lithium silicate. If you have to do a crown on an endodontically treated tooth, I don't think there's a difference there.
Okay, and how do you make sure of this thing that percolation won't be there much if you're using an onlay?
That what may not be that much? I'm sorry, I apologize.
Percolation of fluids, the oral fluids, the percolation of the oral fluids. How can you make sure of it that if you are putting an onlay on it, so there would be less percolation of fluids, oral fluids in the tooth? Okay, I would repeat that.
Not sure if I understand that question. I'm sorry.
Okay, I'll repeat that. Like if you are preferring an onlay preparation for like
Yes.
an endodontically treated tooth, so how can you make sure of this thing that there would be less percolation of oral fluids rather than a crown?
Honestly, the reason, let's just think about what's the problem with an endodontically treated tooth, and why do they fracture? Okay, why is the problem? And endodontically treated teeth, the main reason is not so much changes in dentin composition and changes in it's much more due to coronal tooth structure. And the Donnelly treated teeth fracture, the main reason is loss of coronal tooth structure. So if you, of course, sometimes we have to put a post to support a core, but sometimes we don't. And many times we don't actually, because we don't need to support a core. If we don't have a big access hole, if, and then when I put a post, of course, it's necessary sometimes, but I will also remove coronal tooth structure. So the key is to be as minimally invasive as possible to prevent fracture. Of course, if you have it fracture at the gingival level and you need a ferrule, it's a whole different story. I'm talking about the cases in between. And there, the big concern for me is not anything else but to preserve tooth structure to avoid fracture. And that's, when you're using an onlay, for example. Not for every case, but be smart. Look at the amount of destruction that you have, and right now it's really fluid. There's not the difference between a crown and an onlay is just becoming more fluid. It depends on your preparation design, and then sometimes it's somewhere in between, And that's the only thing I'm worried about. I'm not worried about anything else.
Okay, but I think you did not get my question correctly. Actually, I was just talking about whether if you are putting in onlay restoration on an endodontically treated tooth, do you make sure that all the oral fluids won't enter into the
Oh, I'm sorry. I apologize.
That was the
I got it.
question, actually.
Yes, no, if it's bonded, if it's bonded, right, it's even better than just conventional cementation, I'm sure. Absolutely, yes. Once it's bonded, there's no other fluids going anywhere because, no, not worried about it.
So there won't be any sort of space left between onlay and the tooth? No. Okay.
If you bond it properly, you pre-treat the tooth structure with your bonding agent, you use a composite, you pre-treat the ceramic properly, acid etching and hydrofluoric acid, and then a siding coupling agent. No, it's actually you have, when you use a conventional cementation protocol, you may have much more leakage, okay?
Yes.
With resin bonding, the leakages, and I'm sorry if I misunderstood your question, but with bonding, and we have done studies in that as well, in chewing simulation, where we looked at those restorations, when you use bonding, the leakage is limited, much limited over conventional cementation. When you use conventional cementation, you have much higher degree of leakage into the interface than bonding. Of course, if you don't use proper bonding protocol, if you don't use rubber dam isolation, if you don't, not sure that you have control the fluids, that's a problem. Then it's a problem. Then bonding may be worse than even cementation, if you don't do it right.
Yes, yeah. And now I've got the question and my answer too. Okay, so yes, we are end up with all the question with us.
Okay, great. Thank you so much.
Yes, sir. Yes, sir. That has been like a commendable session, I would say. Having all the questions and even all the doubts and all the problems which usually dentists face, they're all cleared by you, and I'm pretty sure that everyone is quite benefited with this.
That's what we're here for.
Thank you so much, sir. Thank you so much. So,
thank you very much.
Yes, sir. Would you like to add some words at the end?
Well, I appreciate the opportunity. I'm very glad that we could get together in this format. It's a great pleasure to be part of your group, actually, and I'm very proud and that I was inducted into your group. And it's to be part of that is makes me very happy. I can only say, please stay in touch. We are friends, we're a family, and we're in this together. And please, reach out whatever I can do. We're here for us together. Okay. Thank you so much for the opportunity.
Thank you so much, sir. So with this, we'll move on to the end of the session, and we are all lined up with more tremendous speakers like Dr. Markus with us. So stay tuned, and for more updates, you can go to the links given below for the speaker schedules as well as certifications. So thank you so much, sir. With this, we'll move on to the commencement of the session. Thank you.